This is Dr. Erande from Pune, sharing a case of diabetes and its management in brief with you. This is a 45-year-old gentleman. He has come to us for diabetes counseling. His blood pressure is normal. His body mass index is 32. He is having normal lipid profile. His renal function is normal. His eGFR is 90. His urinary albumin creatinine ratio is 20 milligram per gram of creat. His HbA1c is 8.5. And right now, he is taking tablet metformin, 500 milligrams twice a day. From the cardiologist side, he is on metoprolol 50 milligram, ramipril 10 milligram, rosuvastatin 20 milligram, aspirin and clopidogrel 75 each. Now, considering this, when we asked about some of his details, he has had a history of myocardial infarction when he was 38-year-old. So that was 7 years ago. He also has a family history of premature coronary artery disease. Both his parents, one of his uncles, so that's a strong family history of premature coronary artery disease. In fact, his uncle has succumbed to sudden cardiac death when he was 54-year-old. On this background, let me actually put in some of my thoughts. You now understand that he needs a better diabetes control and 8.5 to at least 7%. So 1.5% lowering expected. Naturally, ADA, EASD and all the other world guidelines, ACE guidelines, they will certainly think of using 2 anti-diabetic agents, maybe on the top of metformin as well. Point number 2, he is a person who already has an established atherosclerotic cardiovascular disease. So certainly we will have to give him treatment which is aligned to that established atherosclerotic cardiovascular disease. So 2 molecules immediately come in picture. One is an SGLT2 inhibitor and or a GLP-1 receptor agonist. From the point of view of avoiding hypoglycemia, he is a working bank officer. These drugs will not bother him. From the point of view of reduction of weight, both these drugs or either of them can certainly give a good weight reduction. And especially drug empagliflozin has certainly been proven to give lot of cardiac benefits. You are aware of the EMPARE trial, and this trial has shown us that there is a 3-point MACE reduction, relative risk reduction 14%, absolute risk reduction 1.6%. Cardiovascular deaths, they have the relative risk reduction is 38% in EMPARE trial. And of course, there are renal composite, which is relative risk reduction 46%, heart failure hospitalization 35% relative risk reduction, and 32% all-cause mortality reduction. So as per the EMPARE trial and as per the European Society of Cardiology, ADA, EASD, all world bodies, we should certainly think of giving empagliflozin to this gentleman. It will serve the purpose of protection to the heart as well as kidney. It will help reduction of weight. It will help reduction of HbA1c. But on its own merit, it can bring down HbA1c by maybe 0.6, 0.7, max 1%. So still the patient will be far off from the target. So we will certainly think of actually a GLP-1 receptor agonist, but to make the matter convenient, we will certainly think of a gliptin, which is in a layman term, it is a younger brother of a GLP-1 receptor agonist, though not as robust in weight reduction and as RCT proven for ASCVD protection. It's still a drug like linagliptin in the trial Carolina has been proved to be in the Carmilana trial also. It has been proved to be cardiovascular neutral, doesn't pose additional risk, even in patients who are high ASCVD risk. So we can certainly think of a combination of empagliflozin, linagliptin, and that can certainly be expected to take the gentleman to a HbA1c level of around 7%, maybe in a period of next 12 to 24 weeks. So this is as far as the glycemia and the organ protection is concerned. It is important to actually share with you some of the other features and importance of a combination drug. Any combination therapy, let it be 4 anti-COX drugs or 2 antihypertensives, 3 antihypertensives, 2 antidiabetics, 3 antidiabetics, The main purpose is to reduce the pill burden from the patient's angle that can improve the patient's compliance to the prescribed treatment. At the same time, this improved compliance can take him to the intended target of blood pressure or of blood sugar. And at the same time, the patient's cost, the two separate drugs, empagliflozin and linagliptin separately, may cost higher than the combination of empagliflozin and linagliptin together, because the companies can sell it at a cheaper price compared to the empalina separately. So that is something which is saving on money as well. So all in all, fixed dose combinations of empalina will be certainly useful to the patient to improve compliance, to take him to better HbA1c target. And from the science point of view, there are 8 pathophysiological features of type 2 diabetes, as you know, the famous octet of Professor Ralph DiFronzo. At least 5 or 6 of these pathophysiological defects of type 2 diabetes will be handled or addressed by a combination of empagliflozin and linagliptin. Other subtle feature is the hyperglycemia, which can be caused because of an SGLT2 inhibitor like EMPA, can be addressed by linagliptin, because linagliptin, the incretin class of drugs, also address the alpha cell pathophysiology, and they certainly reduce the postprandial hyperglycemia through the alpha cells. So that certainly can be tackled. Other very important thing, SGLT2 inhibitors like empagliflozin, the most common adverse event or side effect is genitourinary mycotic infections. And when we use the empalina combination, this side effect also is observed to be certainly reduced significantly. And this has been commented on by lot of, you can say, world-renowned professors like Professor Julio Rosenstock, etc. Very importantly, there is a recent publication in the JACC Heart Failure Journal. And what they tried to do was EMPA-REC group of patients, around 7,000 odd patients. They classified into 3 different categories. One category was diabetes duration less than 5 years and younger in age. Second group was chiefly ladies. Of course, there were gentlemen, but chiefly ladies. Diabetes duration between 5 to 10 years. And the character was more of a non-coronary vascular disease. So more of cerebrovascular disease, more of peripheral artery disease, etc. And the third group was diabetes duration more than 10 or 12 years, LVEF reduced, and EGFR also compromised. So long-standing and cardiorenal established problem, these 3 groups. But it was observed that the benefits of empagliflozin, specifically the cardiac protective benefits, were almost equally perceived or almost equally observed in these 3 different groups of the EMPA-REC patients. So that is something which we really want to look at. Our patient belongs to probably the first category. Diabetes duration is, let's say, around less than 5 years. He is young in age, and he actually has a ASCVD like any other EMPA-REC patient. So he also is expected to reap benefits of empagliflozin. There are certainly, you can say, recent articles on EMPA-LINA combination, especially Jammu and Kashmir Medical College has published an article in the July issue of JAPI, and we can certainly refer to that. They have observed EMPA-LINA combination to be certainly useful for glycemic improvement, for weight reduction, on the background of whatever ongoing anti-diabetic drugs in their group of around 385 patients. The story of SGLT2 inhibitors started way back in 1836 when D. Koenig actually invented florizine, which was a part of the root bark of apple tree. Then von Mering tried to actually show that florizine can cause diuresis and glycosuria. And then on, this was catapulted into something which is an invention of SGLT2 inhibitors. In the year, this is the 100th anniversary of insulin discovery, and we certainly hope that the remarkable change in the diabetes treatment which insulin has caused, we can certainly look up to empagliflozin and the SGLT2 inhibitor class as something which is a revolutionary as far as treatment of diabetes is concerned. Both glycemia improvement, help to the blood pressure, at least systolic blood pressure, subtle reduction, lipid friendly, cardio-renal protection proved by rigorous randomized controlled trials and very many other benefits. In fact, the European Heart Journal recently had given an editorial, August issue of EHJ. The editor says that the SGLT2 inhibitor story is still unfolding because we are certainly seeing more and more benefits of that. What with canagliflozin proving to be reducing the events of hyperkalemia in the credence trial. So you can keep on appreciating this. There are very few occasions when a drug's success needs to be explored into the depth, and we have to keep on studying more and more of the drug or the drug class simply for the extent of tremendous success which it has given in the randomized control trial. So this is a pleasure and a pleasant surprise, and you can say a good, exception as far as the randomized control trials are concerned, because we are more used to explaining the failures of the drugs in our randomized control trials. So my friends, in short, this patient is somebody who is perfectly suited to be put on empagliflozin linagliptin combination from the point of view of cardiac protection in particular, and bringing down his HbA1c, improving his weight, and keeping him lipid and renal stable. So this is something which I wanted to share. I certainly thank Lupin for arranging this particular audio session for me, and I'm sure this will be certainly contributory to the thought processes and practice to all my friends who are listening to me. Thank you so much.